So I'm going to, these provide very good summaries, so I'll just, we'll just go through these. But the topic was osteochondritis dissecans, and this is something that you see from time to time coming through your door. So the more common one we see with the, we go down to the epidemiology, is the juvenile form. And often the sporting athletic kid who suddenly gets an effusion and pain, unexplained pain in the knee, usually is not, has any particular mechanism associated with it. And then occasionally we'll see the adult ones where they've been missed during the juvenile stage and they've gone on to develop some consequences. So occasionally we'll see those come through as well. So anatomically, we're just going to concentrate on the knee today. And so the posterolateral aspect of the medial femoral condyle is where most of the lesions sit. And we'll go through some radiology in a tick looking at that. So who's at risk? Well, we're not sure what causes it, but the underlying mechanism appears to be a vascular one. There's a watershed area in that particular area of the knee where the end arteries aren't supported by other vascular supply. So minor trauma in that region can create an area of avascular bone. And that's where the trauma history comes in. And there's also theories behind repetitive mechanical stimulus, such as high intensity training in the young athlete. What we see is the cartilage starts to soften over the top of this, over the top of the avascular bone, and it's essentially a race to get this bone to heal so that the cartilage remains intact over the top. And then they range from softening to early separation to where the lesion's starting to detach, where you'll see a split in the cartilage, allowing fluid in behind the bone. And then once you get the fluid behind the bone, then you can get osteochondral separation. And so you'll get a piece of cartilage attached to some dead bone that then becomes a loose body within the knee. So they're classified as such, where arthroscopically, this is a arthroscopic classification, not a radiological one, where you'll see depression of the cartilage. Sometimes you'll see nothing, which is good. You'll go in and have a look, and the cartilage looks absolutely normal, which is what you want to see. If you see a depression in that region, that means the bone behind it's starting to fail. Type 2s is where they'll start to fragment, and you've got it hanging on by an osseous bridge, and then you can have a detached, non-displaced fragment. So a fragment sitting in the defect, possibly held in by some fibrocartilage or scar tissue, but it's about to become a loose body and then a displaced fragment, so the type 4s. So what do they present with? Well, pain's the main thing, activity-related pain. Mechanical symptoms indicates a loose body, so that's a concern. And the recurrent effusions is often the more common one you see, is knee flaring after activity. So you might pick up some swelling. Tenderness is hard to elicit because of the position of the lesion. Wilson's test, you might be lucky to elicit some discomfort that way, but I find that unreliable. That's basically bringing the lesion into play with rotation through extension. You might be able to provoke some tenderness. So always start with an X-ray with the knocked views is quite helpful. You'll pick up some subtle appearances there, but mostly anything from the type 2s onwards you'll see. But MRI is the gold standard. So if you've got a normal X-ray, go to MRI if you suspect this is going on. This will give you a very good indication of what sort of lesion we're dealing with. In fact, it's probably better than arthroscopy because it gives you an idea of what the bone looks like behind the lesion, what the state of healing is, and can give you an idea how long we're going to be treating the patient for with conservative measures. So it moves into treatment, and the majority of these are treated non-operatively. So
Ben, can I just ask you a question there? Just
Yeah.
on the X-ray.
Yeah.
So I always order that kind of notch view, and quite often it comes back negative.
Yeah.
Does it have to be like a type 2 or type 3 to see it on an X-ray? Like,
pretty much.
Yeah.
You won't until you see some changes in the bones, until you start to see some of the bone fragment and collapse, you won't pick it up. You'll just get that a bit of a loss of the cortical outline. So they can be quite subtle to pick from an X-ray, and by the time you're actually seeing them on an X-ray, they're getting into the more advanced types. So you'll pick up the 3s and 4s, loose body and a detached one, but the more subtle ones, MRI. And often they'll come through with an X-ray, but MRI is the gold standard to be reaching for that very early on.
Yep, perfect. Thank you.
So, treatment's more sort of in the hands of the sports physicians, really, with these, and physios, because you've got to prepare them for a fairly long period of sitting on the sidelines, away from sport, avoiding impact exercise, and be interested to hear what the physios, how they manage these. But you have to restrict the weight bearing and brace. Bracing is probably more about just slowing up some of these kids, because they can feel quite normal in between episodes when they flare, but as soon as they go out and go back to football or netball or go for a run, they'll get swelling and pain again. And with open physes, there's a very good rate of healing, so which differentiates it from the adult form. So while the bone's growing and there's metabolic activity there, it's got ability to heal a lot better, and that's what we see with fractures with young kids. So stable lesions with kids with open physes, they got much better outcome. So somewhere between 50 to 75% will heal without fragmenting, and that's the end goal, is to try and nurse this along so that it doesn't fall apart. So we'll get into some of those, and I've got a few tales of woe I'll take you through. So if you've got one, just try and manage them with their restricted weight bearing. Is any of the physios had any experience with this?
Hey Ben.
Hello. Oh, sorry, you got Kim.
I think the ones that have been that sort of at that more advanced level, they're super load dependent, in that you can get a really good clinical read on their flares with their weight bearing activity, even at the sort of quiet end of their weight bearing activity.
Yeah.
So in that sense, you can really work out a way to really cut them back on their load to sort of get it into the sweet spot in terms of not causing any clinical symptoms. But the hard conversation, of course, is, getting them to drop back to the level that is required. Because a lot of these kids that have actually come in with this have been on that really extreme end of, physical training and loading.
Yeah.
That you see, and all of a
They're
sudden
usually the next superstar in the making.
Yeah. Yes. Or mum and dad think so anyway.
Yeah.
But you get them to that stage of where, they're not even sort of able to participate in the shoot around at school or any of that sort of stuff, and they've gone from it's really the delicate conversation in and around what are the alternatives that they can be doing that is still going to be positive for their longer term sporting goals.
Yeah.
But otherwise, the management in that sense is straightforward. I might hand to Chris to sort of talk about the actual how we as a clinic probably approach the strengthening of people in this age bracket for the juvenile ones.
Can talk to that now, or do you want to keep going, Ben? Does it come up later, or what's?
Yeah, I'll zoom through the operative treatment stuff, but I guess the thing is, this is probably one of those sort of true multidisciplinary management problems, because often we'll get sent them when they're grade ones. And the parents will say, "Oh, look, they're frustrated with the messaging. Little Johnny's on the sidelines for the rest of this year. He's going to be the next Tony Modra, and they're caught between, he's been left behind. But surely there's something you can do. You're a surgeon. Must be able to fix this." But most of what we're doing is trying to get them back to a grade one. We're trying to stop that bone collapse, and the messaging there is that the bone has died. If you keep jumping around it, it's going to collapse, and then it's not going to support the cartilage, and the cartilage is the main event. If we lose that support of that cartilage and lose the contour of the bone, then we're always on the back foot. So all these little things here are all about trying to improve that and trying to keep them on side. And I sort of give them a longer, sort of a bigger picture to say, okay, well, 10 years from now, you can let him play football now, but in 10 years from now, he won't be a very happy person with a constantly sore knee, and we'll be looking at a replacement for him in his 40s. That often brings them back onto the same page, but we just got to sort of look at the short term and the long term goals, and we often pass that off to you guys, unfortunately, and we say, okay, it's off to the physio or the sports physician and to manage that, and you have to deal with a lot of the frustration. But with the operative stuff, diagnostic arthroscopy is done really when you can't really get a good read of the lesion on the MRI scan. Is there a split in the cartilage? Are we starting to see some contour changes? Not done so much these days just to inspect the lesion, because the MRI does a very good job of that. But it's only if you're starting to get, if you've got a grade one lesion, but they've got an effusion, that usually means that there's something mechanical going on. You can have pain without an effusion. That tends to be more classic type 1. But if you're getting the effusions, it means there's probably a subtle area where the cartilage is opened up. So in that case, then we're looking at, there's a few little things you can do then. If there's a breach in the cartilage, then I'm quite comfortable doing a subchondral drilling with a K-wire. And what the principle of that is that you're creating a channel from the live bone into the dead bone for vascular channels and healing to penetrate into that area. There's a point where you can overdo that and you can destabilize the lesion. So that's something you have to be very careful with. You can either drill through the cartilage into it, or you can drill from outside the joint down into the lesion, and that's a trickier thing to triangulate, and there's techniques using II to try and achieve that. But I'll from a simplistic point of view, if I have a look at a lesion and the cartilage over the top is intact, I don't mess around with the cartilage. I don't create a breach in the cartilage with any drilling. But if there's a split, then I'll use that split to drill through that area. And that, again, you need to slow them up and watch them. And that can improve the healing rates. If you've got an unstable lesion, then we're getting into a whole lot of trouble here. So if an unstable lesion is where when you press on it with the probe, it moves. If you can get a probe underneath it, or if you're seeing fluid on the MRI scan that's got behind it, and they're the ones that you should fix. And so there's various ways of doing that. There's little dissolvable screws that you can use to fix them in place, and little Herbert metal screws. I like the little flexible dissolvable ones, because if there's a area of collapse, they don't cause that other damage. And I'll show you some examples of that in a minute. And then we're getting into ugly things like condyle resurfacing and knee arthroplasty. But there's a few. We'll move away from that at the moment. So the techniques here. We talked about the fixation. So you got the little bone pegs, the little Herbert screws, or the cannulated screws. We've got we've got little grafting techniques using the Macy and autografts, and periosteal patches, which we're not doing so much these days. All right, so what I'll do, just give me 1 minute. I've just had a major, my little pad has decided to switch off. So give me 30 seconds, guys. Sorry about that. Talk amongst yourselves.
How's the weather? It's amazing.
Sorry about that. Yeah, I had to go raid my PA's desk for some batteries. These wireless keypads are great, except the batteries ran out. That's good timing. I think I'm back on. Here we go. All right, so what we might do is we might just have a look at a couple of examples. I've got some clinical ones, some of my problem ones that I've had to deal with, because they're never easy. Let's bring it back to here. Now they had a good one here. I'll show you this one. So everyone can see. So I guess this is a good example. You can see the MRI changes here with the zone of injury with good overlying cartilage. So this will be a type 1. Cartilage contours preserved. There's perhaps just in this front corner here, just a little bit of collapse. The physes are closed here. That's the important thing. So again, as that zone sort of brings itself down onto the this sort of, if you're looking at the white of the bone here, then you've got this black rim. That's the zone of injury, and that's crept down onto the cortex. So that one's sort of pretty close to healing. And if you look at this example, you can see the fluid in behind all that lesion, which is just sitting out there on its own. And that's a completely loose one, which needs fixing. So I'll go to a case which will be good. That image there showing a completely loose bit floating around the knee. That's always disappointing to see that one. Now I'll go to.
And just while you're getting that up, can I just ask you, like, when you treat them conservatively, what kind of interval do you use? Do you use 6 months as your interval for another clinical examination, or?
Yeah, I do 3 monthly MRI scans.
Yeah.
The bone healing and the progress of the healing is annoyingly slow. So you end up sort of, I think if it's 6 months, you'll get a frustrated patient. I think 3 monthly, you'll pick changes, and often you'll make decisions on changing tack to trying to speed things up with a maybe a little drilling procedure or forage procedure to try and progress it.
Do you brief the parents and say, listen, if we treat this conservatively, I think your child may be out of sport for 12 months, or do you start with 6 months and then do you give them the worst case kind of straight up? Or?
Yeah, I'd say be prepared for 12 months out, and we might, and if we're lucky, if we're seeing progress in the next 2 MRI scans, it could be back earlier at 6. So prepare for 12. But the reality is, I've had cases that have spun on for a long time, and they're always a bit hard to know what to do, because you can either accept that some of these will just be stable enough that they are hanging in there, and then you need to, do you go and pull it all apart to try and get a resolution? I think they're the really hard ones. I think the hard bit is being patient, just watching it. So I've got, so this one here came in recently. So this girl is 17, I think, 15, sorry. So she is a tall, she's probably close to 6 foot. She's 15, avid netballer, and presented with discomfort after playing, and came in with this MRI scan. Everyone can see that image all right?
No, that one's not protected yet.
Okay. I'll give you that one. So you got that one?
Yep.
Yeah. So you can see that that image down the bottom corner. Sandy, you're the radiologist. Give us a little, what do you think of that one? You there, Sandy? No? I'm going to ask him to unmute. Sandy?
Oh, sorry about that.
Yeah. Yeah. Did you want to?
Yeah. My apologies for the mute. I was just saying, can I see the picture without the cursor? It's just hard to see the lesion, whether there is a fluid cleft behind it to make it 1 or 2 versus 3 or 4.
So you got that one? As I roll through it?
Yeah, on the right. So there's some bone marrow edema on either side of the zone of transition, but I can't see any fluid behind it, I don't believe. It's not detached, so it'd be grade 2.
Yeah, look, I think I'd probably give this a grade 1, I think. Just because it's there hasn't been any collapse.
Okay.
Well, actually, just that little there's this little corner here. That's
right.
if you had scoped this, you'd just see this little cleft in the corner potentially. And there's a little bit, you can see there's a bit of healing bone that's in that cleft. So that's the thing to watch there.
Right.
But you can see that zone of injury here. And there's a bit of edema on top of that. That's the healing zone. And then with this bit of bone, we just got to jolly along. So this one I've just said, do you have to stop any impact sport? Which my mother looked at me, she looked absolutely horrified because she's she's a star netballer in the making. But it was interesting. I'll show you her sister's case in a minute, and I'll show you the course that her sister went down. But so her physes are on the way to closing. They're virtually closed. She is at that sweet spot where we're going to have to try and manage her non-operatively for as long as we can, because the last thing she needs is this thing falling off and you've lost 50% of your medial femoral condyle. So Chris, what would you do if you had this come through your door? Chris or Kim?
Well, I think you've got to be, get a really good workup of. Sorry,
Kimbo. Sorry, man. I just started talking. I did a Sandy. You should have heard what I had to say. It was amazing.
Yeah.
Do you want me to keep going, mate? You've already
keep going, Chris.
We're generally guided by the ortho and the sports physician in terms of weight bearing. So you guys are across the grading and depending on how confident you are with getting back to doing things, but it's absolutely just a slow burn with these. And if they're sore, it's easy because you can, they're not going to run and jump, but if they start to feel like they can, that's where it's very difficult. But we just look to strengthen around it best we can in that non-weight bearing, non-impact sort of way. I think Ben, you hit the nail on the head when it's a multidisciplinary, because I wouldn't manage this on my own. There's no way. I would be completely guided by you guys. And then if things are going down a path that's not working from my point of view and symptoms are worse, then we'd get them back to see you sooner and get some more advice. So,
it's just having everyone on message, I think, is a consistent message across the board. And
the not promising the world is so important as well, 12 months. It may be more, you're right. And you see them drag on for a couple of years before they're really back into it, some of them. I think even the grade 1s can take just as long, but I don't know, what do you think?
I think they're probably the more frustrating, because you're just sitting there watching this thing and you'll see it, you're getting an MRI at 3 months and you go, well, is there a little bit of change there? And the parents are looking at you going, why are you doing nothing? We're just, we've lost all this time.
Do you find, Ben, with the 3 months, there are times when there's no change?
Yeah.
And then you go, well, we should have waited 6 months, and then because they're disappointed.
Well, the way I sell it is I say, well, it's no worse.
Yes.
So, because we could have, it's still a grade 1, which is where you want it to be, because we could be a grade 4. If we'd let you play, this thing could have fallen off, and then you're really not playing anymore, because we're in a whole lot of trouble. Because I've had cases where they've been in and out of theatre, 3 or 4 times in 12 months. going, fixing up things, and recurrent effusions and new mechanical symptoms, and so it can be quite a big circus to try and once they go into those higher grades, they can be a real nightmare. So it's all about, okay, this is what it is, and if we can just maintain this and let it heal and do its thing, then we'll be fine. But you don't want to add anything into the mix that's going to provoke it into developing into a higher grade. But unfortunately, this occurs in these kids who are smashing themselves on the weekends and doing 7 trainings a week and on that trajectory to greatness.
Do you think, Ben, that these are more common? Do you say they're more common in that population, or do they only show up because they're so active, and there are plenty going around that we don't kind of know about?
My feeling is it's always that kid that grows really quickly, but they're training like crazy. So it's always the tall kids, and they tend to be self-select, don't they? So they're the athletic kid, and they're taking off in their growth, and all of a sudden that they're in that sweet spot from sort of year 8 to 10 where the training just starts to compound. They're not only training for school, but then they're training for their club, and then they're doing maybe some state stuff, and just adding it on top of everything else. So yeah, these are always the tricky ones to manage. And they'll shop around too.
Can I ask with this one where you went from a weight bearing perspective as a
grade one? I've said no netball this year, and we're dropping any running, and we're just allowing her to get into the gym just to do some body weight stuff, but no impact. So we're removing any impact work. So she's on an exercise bike. I've talked about getting in the pool. But it's basically just cutting out the running and any court sports, and just try and nurse this one along.
You see it in a lot of young tennis players who train 6 to 8 times a week, and mum and dad are very keen and pushing really hard.
Yeah.
They're the hard ones to get off the court. Yeah, it's a hard sell.
It is very hard because everyone's going to move ahead of them, and they're going to lose their chance. But if you sell it, I'll show you one where if you don't listen, things go to shit. I'll show you this case. So this is the sister of that MRI scan. So there's quite a difference in age between them. There's about 15 years difference. And this is a girl I saw back in 2010. And she was just moving into her early 20s. So she, similar build and similar trajectory in terms of her parents' ambitions for her netball career. So she had a few niggles in her knee whilst playing, but never really got it looked at, and then turned up with a big effusion and a wasn't locked, but she had pain all of a sudden. And MRI showed this lesion. And these are the intraoperative photos, but if you look at the top right-hand corner, that's the loose body. That's the piece of cartilage with bone that fell off. And it's huge. It's about sort of 3 by 2 centimeters. And if you look at the image number 4, everyone see that? That's a big hole in the medial femoral condyle. And that's a disaster for someone who's only in their 20s. And if you image number 5, you can all see that one.
Yep.
So it's just, it's just a big gaping hole. And that's the thing you want to avoid. And that's a classic sort of grade 3 that's been sitting there for a while, just hanging on by a few threads with the fluid underneath, and it's just pistoning and out it comes. So this one, we opened her up, and that's the image number 8 is the piece. So it's a big chunk of cartilage, but it's all in pretty good condition. It's just a big piece. So what we did is we plugged it back in. So image 8, 9, and 10. You can see these little holes in here. They're the little pins. And so we stuck it back into the spot. We used a bit of tissue glue, which is, I think, called fibrin glue. So, and these scope pictures look a bit funny because they're the dry scope pictures because we've opened it up. But we're quite happy how that looked, and slowed her up, gave her time. I think about 2 months later, we're back in there because she got an effusion again. And if you look at image 2 and 3, you can see the lesion looks okay. So you can see the little pin sitting there. The edge of it looks all right. If you get down to the back, there's some healing tissue breaking through the edge. There's some fibrocartilage there, and that's around that edge there. And they see this bottom 2, there's just that little defect developing. And these are the little things that just to create these effusions. So what we did is we microfractured that. So we put some drill holes in that bone to try and get some fibrocartilage to grow into that. And then 5 months later, we're back in there because the effusion started again. And this is where it gets really good. So we're inspecting this lesion again, and you sort of from outwardly on image number 3, you think, oh, that looks okay. Image number 4, that little back corner, we did the microfracture. It's all starting to fragment. And this, where this arrow is here, this you can see this little clear plastic thing. That's one of the little pins that's now starting to get exposed. And you think, oh God, this is all going to hell. And you look at the edge of it here now on image number 5, and that part of it's hanging on, and you got granulation tissue. So this is actually encouraging. If you're seeing blood, bleeding bone, you know you've got healing potential. So that's actually a good thing. It's trying. But all of this had fragmented off, and so we had to lift that flap off. And this is what's underneath it. So we've managed to keep the front half, and the back half has been lost. And so we've just got a bed of bleeding bone. But that's actually, although it looks terrible, it does actually have some good chance of developing some fibrocartilage, which is, it's not the original hyaline cartilage, but it's better. And then 3 months later, we're back in there again. This girl put my kids through school. Because she was going okay, and then some effusions developed again. This is looking at that lesion now, and that area that we microfractured, it's got fibrocartilage in it now. So that's the final result here. You got retained portion up here that we managed to fix, the back corner that fell apart. We've got some coverage now, and I haven't seen her back. Like she's gone off, and when I saw her sister the other day, I said, you know, she's all fine. So Mum's saying, why can't you do what you did to her sister? And I said, do you understand how much sleep I lost by trying to get that to heal? So I would rather not go down this path. I'd rather, you know, not take you to theatre, you know, 3 or 4 times in 12 months and open the knee up and try and jolly this thing along. So yeah, so at the end of the day, we need to, it's all about slowing them up, and when something does change, you often just go, so what happened? You weren't playing sport, but you went for a run on the oval with your mates at lunchtime. And it's often those little breakouts that you go, oh, okay, things have fallen apart. All right.
Hey Ben, Sandy, just on the surgical side, like, so with your microfracture in this type of scenario, or just in general, do you think that joint rep, which unfortunately has now got culled from the PBS, is beneficial for healing?
Yeah. Oh, that was such an excellent addition to our weaponry for this, because it was just like that previous defect I showed you. We would have squirted some joint rep into that, and I mean that the result here is not too bad. I mean, it good with good vascular bone in young people. The rate of infill is quite amazing. I mean, I'm really pleased with how that one looks in image 4. It's not perfect, but it'll do her, and that's pulled her right back from the brink. Considering where we started, that's a real win. But yeah, it's a pity we don't have joint rep now, but I mean, you can get it. They just got to pay $6,000 for it, which is horrendous. Which I think it's a bit of a disgrace, but it's the way that product is classified. So it's classified as an implant, and therefore they get implant prices. So they get the same rebate as you would for a hip replacement or a knee, and it's just a couple of syringes of stuff that you squirt into the knee. So the company's being a bit greedy. So, I think it'll be back, but hopefully they'll classify it differently.
Right, that's very interesting. You probably think they would, because some money's going to be better than zero money.
Yeah, exactly. Yeah.
Hey, could I just ask very quickly, sorry, Chris, would you be able to just elaborate on your non-weight bearing strengthening that you could do in the grade 1 situation? Ben spoke about no court and using bike and pull, but I just wondered, when you're in the gym, what you actually do as a physio for a non-weight bearing strengthening program. If Chris is not there, maybe Kim can speak, one of the two, if that's okay.
Hello. Sorry.
There he is.
I'm having real trouble. So the non-weight bearing exercises. So it really is starting back at basics, and it might be on the floor or bed, or glute, hip extension, hip abduction, some basic stuff so that they can have some stability when they're walking or going upstairs. And so we start with that. You can generally, if they're okay to weight bear, calf stuff's really important for stability back across the knee as well. So we can start calf as well. But the quad stuff, really, a leg extension, they're generally okay with. And so through part of the range, and if they're uncomfortable, say it's leg extension from 45 degrees through to fully straight, then we might just work with a little bit of resistance from, say, 90 through to 45. Or often there's not one range that that all of these, it depends on the individual, but you find a range that's comfortable them to work in and to load. So they're sort of non-weight bearing. In terms of the gym, I wouldn't start with squats and weighted squats, things like that straight away. That would be certainly something to progress onto. And if you're looking at a 6 to 12 month rehab anyway, it's all really, really slow. So yeah, floor, hip strength, hamstrings, quads, calf where you can. I really keep it simple. And if you break it down to the people, this is, and the parents, let's get these muscles strong. Let's find a way that suits that individual, and slowly progress them. So the bike and the swimming is fine. They can normally get a little bit of their heart rate up in that way. They tend to get very bored. That's one problem, because it goes so slow, and it's not quite like an ACL where you can kind of see that they're going to progress, and they can see the progressions. Within their week or fortnight, they'll fluctuate and have good and bad days, and then they're at school with stairs, and you're managing that as well. So basically, I start basically and then progress as able, really. So it's hard to say definitely standing in black and white what you do, but you find a way to load the quads, it doesn't hurt. Find a way to load the calf, it doesn't hurt. Does that kind of answer your question?
Yeah, no, that's really good. I mean, and you also highlighted the point that I suppose, and throw this open, you want to avoid stairs. So I mean, I've written sickness certificates for kids to use lifts at schools for that reason, because the teachers think they're just skiving off and being lazy, but they're not.
Yeah.
So, yeah, thanks, Chris. That was really good. Ben, did you want to add anything, or that was terrific?
No, good. Look, I think, are you guys happy to leave it there for the time being? Any other questions? I know I've just got to run up to the ward in a minute.
Just a quick one. Difference between joint rep and card gel and maybe some other gels. Is there much difference in how they work, or?
Yeah, certainly the joint rep is a lot easier. It's a chitin protein, provides a scaffold for the new for the stem cells and the new cartilage cells. The issue that they had was that the TGA went back through their evidence and said, "Oh, you need a randomized controlled trial." So they retrospectively removed their approval. And I think the RCT that came out of the States, they had a few issues with it. So what's happening now is they're enlisting people in a new randomized controlled trial. So you can still use it here, but you need to enlist people in the trial, which means that 50% will get it and 50% won't. So I think that's from my perspective, it's a bit of a hard sell if you're doing a microfracture and you're sort of opening an envelope to see if you're going to get the good stuff or not, because that's very hard to standardize. Because a lot of those results are going to come down to whether there's the size of the lesion, the position, patient's age. So yeah, I guess we'll be on the sidelines for that a little bit. But my preference definitely is joint rep. I've had some really good wins with that. In terms of just improving the overall surface area of ingrowth of fibrocartilage, and it seems to be a little bit more rapid. It's quite, if you're asking these cells to sort of try and fill in a gap where they're getting repeated mechanical trauma, if you've got something that's protecting them, so they're literally under a little blanket. And it's once this stuff is hardened after a couple of minutes, it's you can put your weight through it, albeit the protocols are in gradual increase in weight bearing over a period of 6 weeks, up to 80, up to 80% of your weight, grading up from 0 on day 1. I think of the results I've seen of that personally, I've been really impressed with. So I'm a bit annoyed that it's now being pulled.
Yeah, I think you're well supported with that, Ben. I've done a few with Dave Herman, and he's not very happy either, given his pediatric population.
Yeah. That'll be a big hole in his practice, and go back to the dark ages, basically.
You got to get some orthos on that board and kick the rheumatologists off, mate. They stuff it for you.
Yeah. I'm wondering how that came about, but yeah, sounds like it.
Thanks,
right,
mate. That was terrific. Really
no
good talk. And thanks for the physio contribution too, guys. That's great.
Yeah, thank you.
Thanks, all.
Thanks, guys.
All right. Cheers.
Thanks, everybody. Thanks a lot.
All right, cheers. No worries.
Thanks.
Okay.
Thanks. See you,
See ya.
Katherine.
See you,
Bye,
Katherine.
everybody.